All right, today we're going to talk about a condition that millions of people live with, atrial fibrillation, or as you probably heard it called, AFib. Now, you might just think of it as an irregular heartbeat, but it's actually way more serious than that. So let's break down what it is, why it's so dangerous, and how doctors have to navigate its really complex treatment. So here's our roadmap. We're going to start with what this unique heartbeat actually is, and then we'll get into its single biggest threat. After that, we'll dive right into the clinical game plan for treatment, see how doctors figure out your personal risk, and then wrap up with the core dilemma that really defines AFib care. So first things first, what in the world is actually happening inside the heart when someone has AFib? Okay, so the medical term is a supraventricular arrhythmia, which, is just a fancy way of saying the electrical problem is starting up in the heart's upper chambers, the atria. But the phrase you really need to remember is irregularly irregular. This isn't just a fast pulse or a slow one, it's completely chaotic. There is zero pattern to it. And if you were looking at an ECG, that first little electrical blip, the P wave, that normally tells the heart to beat, it's just gone. AFib isn't a one-size-fits-all thing. For some people, it comes and goes on its own. For others, it sticks around for a while, or it can even become permanent. But here's the most important thing to get. No matter which type a person has, the fundamental danger we're about to talk about, it's exactly the same. So why is this condition taken so seriously? Well, it's not really about the weird rhythm itself. It's about the incredibly dangerous chain reaction it can kick off. This one sentence, right here, gets straight to the heart of it. This is the guiding principle for managing AFib. Every single decision, every medication, it's all aimed at preventing one absolutely devastating outcome: a stroke. So how does that happen? Well, it's basically a plumbing problem. Because those top chambers, the atria, are just kind of quivering instead of giving a good, strong squeeze. Blood doesn't get pushed out like it should. It starts to pool and get stagnant, and that creates the absolute perfect environment for a blood clot to form. And if that clot gets pumped out of the heart, its first stop can be the brain, where it can block a major artery and cause a massive stroke. So, given that huge risk, doctors have a very clear and strategic way of managing AFib. It's not just one treatment, but a three-pronged attack. The entire strategy really boils down to three main goals. And here they are. First, you've got rate control. That's just slowing the heart down so it isn't racing like crazy. Second, rhythm control, which is trying to reset the heart's electrical system back to normal. But that third goal is by far the most important one: stroke prophylaxis. That means doing everything possible to stop those dangerous clots from ever forming in the first place.
Okay, so let's look at those first two goals, rate and rhythm. What's in the playbook? What tools do doctors actually use to get the heart's wiring back in line?
For controlling the rate, there's a really handy mnemonic that's often used for the main types of medication, the ABCs.
The ABCDs stand for amiodarone, beta blockers, calcium channel blockers, and digoxin. But the real key here is that B and C, beta blockers and calcium channel blockers, those are the standard first-line go-to options for just slowing that heart rate down. Now, controlling the rhythm, that's way more complicated. The decision on whether to even try to restore a normal rhythm and which drug to use for it is super personalized. It totally depends on the patient's other health issues, like if they also have heart failure or coronary artery disease. There's just no cookie-cutter answer for this one.
Okay, so let's move on to that third and most critical goal, stroke prevention. How do doctors figure out what a patient's specific, personal risk of having a stroke actually is?
They use a special scoring system. And yeah, it's got a really complicated name, the CHA2DS2VS-CIS score. But the idea behind it is pretty simple. It's basically a point-based calculator. It takes all of a patient's health factors, adds up the points, and gives a pretty solid estimate of their annual risk of having a stroke.
But preventing clots brings up a whole new problem. The very medications that stop clots, we're talking anticoagulants or blood thinners, they also, by their nature, increase the risk of bleeding. And this, right here, is the central dilemma of treating AFib.
It all comes down to a clinical balancing act. On one side of the scale, you have that CH2DS2VAS score, which tells you the risk of a clot. And on the other side, you have a different score, called has-bled, which tells you the risk of a bleed. It's this constant push and pull between two very different, very real dangers. And you can see that balancing act right here. Just look at how some things, like high blood pressure or having a previous stroke, show up on both sides of the scale. They increase your risk of another clot, for sure, but they also increase your risk of a bleed.
This is what makes the decision so incredibly tough. A doctor has to look at the final scores and make a really difficult call. Is the benefit of preventing a horrible stroke worth the risk of causing a major bleed?
So that has-blood score gives a pretty clear line in the sand. A score of 3 or more is a huge red flag. It doesn't automatically mean a patient can't get blood thinners, but it tells the doctor that they're at a really high risk, and they need to be watched with extreme caution.
You know, when you step back, the story of AFib treatment is really about moving away from one-size-fits-all rules and toward this kind of highly personalized risk calculation. And that kind of leaves us with a bigger question, right? As these scoring tools get even better and more precise, how is this data-driven, tailored approach going to change the future of how we manage not just AFib, but all chronic diseases?